Hi, good afternoon, and good morning to our West Coast attendees. My name is Mary Dorshank, and I'm the Director of the National Colorectal Cancer Roundtable. We really appreciate the strong interest in today's webinar and appreciate everyone's time and making an effort to join us today. Today's webinar is the second in a series of mini webinars that the Roundtable is hosting to profile best practices around 80x18 in a number of different categories. As you know, primary care practices and providers play a key role in achieving increased colorectal cancer screening rates, but many of us have questions about how to select and implement successful practice changes in this fast-paced setting. During this webinar, Dr. Jason Crawford, Chief Medical Officer of the Community Health Alliance of Reno, Nevada, and the 2015 recipient of Nevada's Cancer Coalition Innovation Award, will share Community Health Alliance's experience with colorectal cancer screening efforts, including work they have done to address disparities. We will also, let me just advance that. There we go. We will also highlight several resources that can support primary care practices and providers in implementing best practices, including a National Colorectal Cancer Roundtable 80x18 resource document, What Can Primary Care Providers Do to Advance 80x18? A few housekeeping items before we get started. We are recording today's webinar. The replay and the speaker slides will be shared with all of you within a few days. Please feel free to share with your colleagues who are not able to join with us today. Also, because of the large number of participants, all participants are muted on today's webinar. Having said that, we still want to make sure that you get what you need out of the webinar, so we encourage you to ask questions by submitting them through the webinar Q&A function. We'll have time for questions after the presentations, and we'll answer as many as we can, and we'll also be emailing around responses to any questions we don't have time to get to. You can also always email us specific questions afterwards. And finally, we are always trying to improve our webinars, so we're asking for your help in evaluating today's webinar. So you'll be receiving an email with a survey link. Please help with that by taking in a few minutes to provide feedback. We take this advice very seriously and are always trying to improve. So with that, I'm pleased to turn this webinar today over to Dr. Jason Crawford. And let me just pass the baton to you, Dr. Crawford, and we will get started.
Great. Well, thank you, everyone, for the time. And I know that we have multiple attendees, so I appreciate everybody from the East to West Coast for listening in this morning. So I'm going to be talking about our practice profile in just a bit, but how we were able to do a grant sponsored with our Nevada Cancer Coalition to enhance our colorectal cancer screening rates within our community health center. So objectives for today, taking a look at how we did it through what I'm terming the Bible of increasing colorectal cancer screening rates, the manual for community health centers. And then a quick review of our joint collaborative grant with Community Health Alliance and the Nevada Cancer Coalition with the title there. Some tactics that I thought were essential during our program implementation steps and ongoing efforts will be scattered throughout the presentation, and then a review of what's really a fresh and new and very exciting collaborative that we have within the community of Reno and the Sparks, Nevada area. So I'd like to start my session off by talking about what's really important, because we're going to look at a lot of numbers and percentages, et cetera, but really the story behind colon cancer is the impact that it has overall, and when we have deaths attributed to colon cancer and how we can reduce those deaths and save lives. So I'm a musician, and this guy's Chet Atkins, Mr. Guitar. He died of colorectal cancer. This is Sir Francis Crick, the father of DNA, died of colon cancer. This is my grandfather, Jim Brainy, who's a survivor of colon cancer. I always like to throw him up there. And then this is my father-in-law, who unfortunately died of colorectal cancer approximately 2 years ago. His name is Gary. So these are the important components to why I give these talks and why it's important to enhance your systems and improve colon cancer. So we'll turn to some numbers now. So you all can look at your various states and find your numbers. This is the screening rates in community health centers. you can see that Nevada over here in the west is pretty darn bad at 14.1, so that's kind of a starting point for us. This is 2012 UDS, or Uniform Data System data. So, you know, I always like to say, ouch. You know, Nevada, unfortunately, has proven multiple times that we've had problems with our health indicators, and this is one of them. But we can all join forces in Nevada and across all of our states to improve those numbers by making these changes moving forward. So this is a quick profile of my health centers, as well as the logos for Nevada Cancer Coalition. We're FQHC with currently 6 clinic locations. We have 21 medical providers and approximately 23,000 medical patients. We have about 29,000 total patients. Many are dental. The grant timeline there, and here's moving forward a statement of purpose with the grant, with some targeted grant goals at the bottom being data management, outreach and education, and patient navigation. And as you'll see with the tactics that I'm going to discuss moving forward, these are really the key components to making your successful system-based program to increase your colorectal cancer screening rates. So once again, quick shot of AKA the Bible of colon cancer screening rates, a manual for community health centers. This is a joint collaborative with the NCCRT as well as American Cancer Society, and really has helped me in so many ways to be a part of this increase in enhancing our screening rates, and step-by-step process on how to improve your systems, improve your rates for UDS measures, training your staff using field-tested and evidence-based processes from experts and other areas that have already implemented multiple projects such as this, and gives you a great guide on how to strengthen relationships with your local counterparts, be it healthcare systems, GI docs, health departments, etc. So this is the quick 4-step guide of how to do it. Make a plan, assemble a team, get patients screened, coordinate the care across the continuum. So we're going to go through each of these components and see how we did it and scatter in some tactics. So obviously there's going to be subcomponents amongst all the various steps, and we'll touch on each of these in a quick manner moving forward. So the first thing, step number 1, make your plan, look at your baseline screening rates. Well, they were not so good in 2012, 3.22%. I put ouch there. But guess what? In 1 year, we increased by a pretty high percentage there, but still 6.36 as an absolute increase is 3 percentage points. I still say ouch there. So pretty poor numbers. And this is a cross-section of our QI reporting data using UDS national and Nevada numbers as well as HP 2020. I do have the NCCRT 80 by 2018 on some future slides as well. But you can see how Nevada ranks at 14% and nationally at 33%. So we as a united force with community health centers have to do a much better job. And me specifically with my healthcare system needed to do some very significant changes. So our next process is one of the most labor-intensive processes, is to make a plan by designing your practice's screening strategy. Just what are you going to do? Well, this starts with an education of your providers and your staff as well, to get everybody bought in and understanding just what the heck colon cancer is and how we screen for it, and convincing them that there's lots of evidence that screening works. And a lot of times we don't get that message clearly delineated to us. And so I start this by saying, why do we even screen? It seems obvious, but it's a very important question to make sure you're educating your staff and providers. Well, we can prevent cancer, but we can also detect cancer in the early stages. And so clearly we can see if we detect it at early stages, the 5-year survival rates are much, much, much better compared to when we have a stage 4 distant METS disease at 12.5% survival rate. So the next part of the plan is convincing them, you know what, there's no evidence by randomized control trials that show that one screening method is the best. And many of my primary care colleagues think that colonoscopy is the only way to go. many people forget about our fecal immunochemistry test, or FIT, that's available. And many of them may, I dare say, still be using a in-office one-time guaiac card as a screening and thinking that's okay. Well, that's my job, is to train everybody that that's not okay. So knowing the fact that we can use a methodology such as stool-based testing, then why the heck are we seeing these dramatic decreases? You can see uninsured, insured, and total over the years, just a very dramatic decrease in the use of fecal occult blood testing modalities for screening. For uninsured, insured, doesn't matter, it's going down. Well, we got to get that message out that we need those numbers to go up. And these are just quick reference articles for you. I'm not going to spend any time with these, but these are articles I bring forward to my staff and my providers to convince them, because I'm an evidence-based guy. I say, look, here's accuracy of FIT for colon cancer testing. Here's information on long-term mortality after screening for colon cancer using a FIT-based approach. And obviously, you guys recognize the clinicians, the New England Journal there. So pretty stout evidence that's being delivered, and bringing this forward to your staff, showing them that we can make improvements in mortality reduction using fecal testing is just as good as colonoscopic testing. So not that colonoscopies in any way, shape, or form are bad, but we may not be able to offer colonoscopy to all of our patients. And so a FIT or fecal occult blood testing process should be in your primary modality within a primary care setting, and especially a community health center where we have folks who are disenfranchised, uninsured, underinsured, et cetera. So within one of the guides, we have sample policies that you can develop into a flow sheet format like this. So again, I'm not going to spend the time to go through it, but it's just a methodology and a way that you can develop your own process. So we have a similar flow chart. So that's designing your practice strategy. Now we're getting into assembling our team. So the first and most important part is find your internal and external champions. So your champions can establish your links of care. They can create a force, a driving force within your health center, as well as externally with your gastroenterology colleague champions, your hospital-based systems champions there. So work on that, identify them, educate your team on your system, make sure it's an easy system to follow. And I ascribe to the keep it simple process as well, the KISS protocol. So I always ascribe to that. I like to keep things simple and effective. So here's my #1 tactic, A+ tactic, is the key point that we as clinicians can't do it all. You got to get your staff involved. Make sure your non-clinical staff is being utilized to the height that they can be utilized. And create those standing orders. Get your nurses empowered, your MAs. Let them distribute educational materials. Don't, as a physician or PA or nurse practitioner, don't just set yourself as the linchpin, so to speak, of making this type of program work. So involve your staff in meetings, discuss progress, show your goals. It's very important to show short-term gains at your staff meetings. Tactic #2, when you're developing your team, getting that care, we call them cancer screening care coordinators. Other lingo is patient navigators, health coaches. You'll hear a lot of lingo in the literature right now. The care coordinator really serves as an organizational, clerical, customer service provider for the program. They're really your internal champion, and they really need to be empowered to help you move this forward. We've had several excellent cancer screening care coordinators who have really made this program work for us. They work well, they educate the patients on how to do FIT, and they're really a health coach in many ways, shapes, or form. They talk about barrier reduction, getting people past the challenges that get brought up on why they're not doing their FIT or sending it in, et cetera. They do all the follow-up, keep tracking spreadsheets, make sure that you have compliance. So that is a key tactic for you, is finding that right person. So now let's talk about continuing on with step 2 is partnering with your local colonoscopist. This is really vital, your linkage from primary care to endoscopic and specialty care. And I think that those linkages, luckily I went to residency in the same community. I worked with a lot of the local colonoscopists, so I was able to help to foster and develop some linkage between our two groups, which I'll talk about, our two GI groups, which I'll talk about later. But our GI docs often work in the inpatient setting so they can serve as vital links to the hospital networks, as well as to those advanced care providers like colorectal surgeons, anesthesia, pathology. It's very rare for me to refer directly to a hem-onc or rad-onc doctor as a primary care physician, so I'm dependent on my GI physicians to help me out and create those linkages and foster the collaborative overall. And really, you want to start this early in your process. Get those discussions out there. Sorry about that. Put that on mute. Get those discussions out there. So now we're going to move on to step 3, get your patients screened. This is where it all starts. So conducting a risk assessment, so we know that people can be classified here in the top green boxes: average risk, increased or high risk based on personal history, increased or high risk based on family history. And so we know that a screening methodology does not always fit with the increased high risk folks or based on personal or family history. So making sure that you're following the appropriate algorithms. And on my next slide, again, what do we do to make this simple as anything for our staff or providers? Keeping it simple. Well, here's your common sense colorectal cancer screening recommendations at a glance, and this is all available in the manual for community health centers. Again, make copies, distribute it, talk about it. This is a ready reference to maybe upload into a clinical resource folder that your providers can use on site when they're in their patient care flow with their electronic health record in the room, and say, oh yeah, what do I need to do again? And then they have this readily available. So we got to prepare our patients too, and so it's really incumbent upon us to provide culturally and linguistically appropriate materials to our patients, and there's a wealth of them out there. And the beauty of the manual is that they offer you the links and kind of depot areas of where you can find these types of handouts and modify them. Educational materials. What are our options as far as screening? And the most important message you need to send is that no screening is not an option. So, and we always talk about the best screening is the one that gets done, and that's really the clear message that needs to be sent, because no screening is not an option. We use a lot of fit-based videos and handouts that are culturally and linguistically appropriate. We have a large Hispanic population, so we have Spanish videos, Spanish handouts, Spanish-based language applications, etc. And the important thing as well is using scripts. Let your providers be trained on how to use a script to counsel patients on a FIT or colonoscopy or some type of aspect of colon cancer screening. And it's fine to train to use scripts. It's delivering a consistent message from your staff and your providers. And again, examples of those scripts can be found in the manual. So the key point with this slide is that we need to offer choices. And so you can see the FOBT arm on the left side and the choice arm on the right. When we force patients into a colonoscopy-only arm, you can see in the middle that we have a dramatically reduced, statistically significantly reduced completion of screening rates. So offering a choice is the key and vital to your success in your colorectal screening rates enhancement. So that's the gist of that slide. And using those, what we call clinical decision support tools. So we talked about the pre-planned scripts, using videos, demonstrations, decision tools at the point of care, like the one that's offered here. I know it's in small print, but again, it's available in the manual, comparing benefits, risks, things to consider in the bottom line between colonoscopy and FIT. And once again, using language appropriate materials. The key key point is that a recommendation from your provider is the most influential factor on patient screening behavior. So I try to drive several points home to my provider staff when we're talking about enhancing screening rates for any modality, cancer modality, but specifically for colon cancer in this case, is that you have to make that recommendation. There's clear evidence that that recommendation made by you directly to your patient leads to enhanced rates, even more so than your care coordinators and your ancillary support staff. So this is an interesting slide that I extracted from another presentation that talks about why patients aren't being screened according to physicians. And so you can say, oh, well, they don't want to do the screening, or they have fear of the procedure, or they lack the insurance coverage, or the time constraints, logistical things. This is what doctors think. So then on the flip side, the patients get pulled, and this is what the patients say: my doctor never talked to me about it. Well, please, 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 I'm going to back up and say that recommendation is so important. Get that message out. So now we get into ensuring that we have a quality screening, stool-based screening program. I don't know how many of you are patients that are in medical homes or have a robust quality, total quality management program, but you need to use some type of a tool, be it a Plan, Do, Study, Act quality assessment tool, or some other model such as Lean or Six Sigma or some other methodology to track the success of your program. So the Plan, Do, Study, Act, or PDSA, is one that's well validated in the literature. It adds to your PCMH accreditation, et cetera, et cetera. So the point here is just to use some methodology. So key points as far as the quality of your program: never, never, never use an in-office fecal occult blood test as your screening tool. So this is doing a digital rectal exam and then testing the fecal material with a single guaiac card. This is worthless, and I spared the other 3 slides that drive that point home, but basically you miss approximately 95% of all bleeding adenomas as well as cancers by doing an in-office guaiac card and thinking you're doing the right thing. Now, that's just for screening. Do we still do in-office rectal exams and guaiacs? Of course we do, but it is not a screening modality. It is not recommended by ACS, NCCRT, USPSTF. I won't list any more alphabet, but please don't do that and give your patients false assurance that you're screening them by doing an in-office occult blood test. Make sure you're using a high sensitivity fit. You're doing your annual testing, and the most important part is all positive screening tests should be evaluated by follow-up colonoscopy. So this is another quick reference guide that's available within the manual, as well as at this web link here, cancer.org/colonmd. Another very quickie clinician reference guide. I know that I'm always busy, and I can't overly burden my busy physicians and mid-level providers with a lot of material, so I give them a quickie one-pager, and they can read through it, have that as a ready reference, gives the statistics, the evidence, and say, hey, you should be doing this. So let's talk about another A-plus tactic, as I've been calling it. Really look for local opportunities to get fits for free. Seek out those opportunities. So we have local health systems, we have LabCorp, Quest, etc. We have a local discount healthcare program that offers a free program. We got to get those fits out there. Have them readily available at the time of care. Give them an envelope that has appropriate culturally and linguistically appropriate instructions. Most of the packets do come with English and Spanish by default. Some of them don't. So please look at your fits. Determine if you can buy them in bulk. There is a CLIA-waived fit that is now available through HemoSure iFob test. And so those are available, and you can get your CLIA waiver updated for that and start handing them out at the point of care, because nothing is better than doing it at the point of care and instructing patients, walking them through it, and then getting them to go home, take care of business, and mail it through the mail. or have them drop it off at your office, and then you guys can process it at your office if you're CLIA waived, or mail it out for them. So just make it as easy as you can for your patients. So my next tactic, you got to use those EHRs. Even though we all cringe about EHRs, and many of us on this phone call are probably not too thrilled with their EHR, but there's ways to use them. So that's what they're there for. So we need to activate our tracking capacities through registries or other formats within your EHR. If you don't know how to activate them, well, I'm sure there's a support staff or IT, I hope, that you can call to help you out with that. Add patient flags, reminders. I love reminder systems and using patient alert notes in my EHR. Use standardized templates. So I have a lab order template that I can just click on that says fit. It already has the ICD-10 codes built in. It has the fit order already processed, and all the instructions are auto-populated onto my patient's encounter and their care plan, or what we call an after-visit summary. We call it patient care plan. So template it out, make it one click instead of 100 clicks. The less clicks, the better. Run reports. Always be looking at your data. More frequently run your reports and evaluate your data. Many of us have to, well, all of us have to pass meaningful use pretty much, and we look at those clinical quality measures on a monthly basis and then deliver the message to our clinical staff and provider and other staff quarterly. So here's an example of a screening and prevention tab that we have built into our electronic health record. When I open a chart, it defaults to this tab. This is a person who has several things listed here. You can see that colorectal cancer screening is highlighted, and they had theirs completed as of June 5th. They're good for a year. That means it's blue. When they're due, it says red, and so that's how we use our screening and prevention dashboard. This is an example of my template that has the fit built in under a lab order. I'm not sure if anybody's familiar with MicroMD. That's a Henry Schein EMR product. That's the one that I'm showing you here. We don't have one of the big ones like GE Centricity or Epic, but all of them pretty much have the same functionality. And so build it in, create an adult visit template or screening template and just build it right in. We still use dual ICD-10, ICD-9 coding, so you can see there. The order gets auto-processed and goes right through. So again, one click to make all that happen makes your life a lot easier. So then tactic number 6 is really leveraging that data, making sure that you're showing your staff the data and the awesome work that they're doing. Always make it a short-term win for them for your long-term goal of your project. They have to see and be provided continual acknowledgement of the gains that they're making. So I like to use unblinded data for all of our quality reporting across the board. So all of our provider level data, and we're building it into teams, because all of our teams will have team care assistants and care coordinators, and each team will have comparator data amongst the other teams. As it stands right now, we present the data by provider, and all the providers get to look at everybody else's data every month to quarter. We have a quarterly QI meeting where we all address, and it allows us to develop best practices, encourages a little bit of a competitive spirit within our provider group. And really this goes beyond me saying, march, take these and roll with it. The provider staff need to be empowered and bought into to your system. And again, we want to work as a team at Community Health Alliance to create a full team-based approach to make this happen for our population. So, so 2015 pilot project results. So as you know, we started with the very dismal 2012 to 2013 at 3.22%, and in first quarter 2015 we had an overall, that should say tenfold. Sorry about that, I adjusted some of the data points. So we went up to 37.29%, and I was pretty darn happy with that. And I'm missing, there we go. So I corrected it here. So 10-fold increase in screening rates compared to where it had been. And then I just ran some numbers yesterday, and we are now at 37.37. So we've seen a huge, dramatic climb through the program and kind of a leveling effect. So now the question is, what more can we do? We got to get back out there, reevaluate our program. We need to, this is the act part of the PDSA cycle. We need to act upon our study data and figure out why we're leveling off and not improving, because we want to see a trajectory of getting all the way over to that reddish brown bar on the right side, which is the NCCRT 80 by 2018. We want to get that movement up there and get all of our providers A through F. This is only 6 of our 21 providers presented. On the left side, it says Community Health Alliance, and you can see where we started with the 2013 year-to-date red bar and the dramatic increases that we've had. Some of that is, yes, tracking and making sure we're getting the appropriate acknowledgement on our data reporting, but you can see a steady climb over the quarters to where we are now, which we're approaching 40%. So by my calculations, that gives us a little less than a little bit more than a couple of years to get up to 80%. So I think it's an ambitious but achievable goal, and I think we're heading in the right direction. Many of our providers are showing significant gains on this, and it's all about all those preceding steps to get us there. So finally, step 4, coordinating the care. We really need to create that, what we call medical neighborhood in the patient-centered medical home lingo. It's really critical to making sure that our patients that are identified with positive fits or cancer are getting the care that they need subsequently. So what we've done is over the last 6 months, I've identified 2 local GI champions. We had shared spots at a Nevada-based cancer medical advisory board, and so I tapped upon them and said, hey, here's what I've got concocted. What do we think about developing a collaborative locally to hit the targets? And it started as specifically for my patient population, but has built out to being a larger collaborative. We have 2 large GI groups in town that by and large do all of the colonoscopies. So I've identified those champions, and each champion has helped to champion the cause with our 3 major local healthcare systems in a top-down approach. So really getting CEO level and the C-suite people, CMOs, COOs, CFOs on board is key, and then filtering down to where the boots hit the ground is important. We just had a collaborative meeting with one of the local health systems and have our homework assignments on developing further collaborative and making sure this all works out. The screening part's the easy part. Once we figure out who is positive and we identify colon cancer, that's when the expense part comes out and where we need to have collaboratives. And I really, I'm not reinventing the wheel here. And I have a slide on talking about not reinventing the wheel, so we'll talk about that in a moment. So next tactic, know your needs, translate it to cost savings. This makes such a big difference when you can bring calculations forward to your health systems and GI champions to get them on board. The manual gives an awesome calculations template to estimate your annualized need for colonoscopy. I had this data readily available, provided it to the GI champions and the local healthcare systems, and I've worked those numbers into cost savings based on analysis of how the overall cost of taking care of stage 1 to stage 4 patients with cancer. And this really creates what you call a value proposition for the community and creates a bottom line that looks happy for the finance people but has great impact for the clinically minded folks and everybody in between. So this is not to be really reviewed in any detail. This is just a sample of my calculation template that I used. So we estimated that we'd have a need of roughly 72 colonoscopies. We got 60 colonoscopies offered to us by the 2 groups. And out of that, considering approximately 5.45 of those colonoscopies that were FIT positive are going to end up with cancer. And then I gave some cancer cost data down here based on some other articles and evidence. These numbers seem kind of low to me, but it's just some evidence I had, and I've been able to bring this forward showing what the cost savings are to a system. For instance, if somebody with stage 4 colon cancer presents to the ER, what that's going to cost to their system, especially if they're uninsured, and how we can offset that with the colonoscopy that would cost instead somewhere between $1,500 to $2,000. So here's my do not reinvent the wheel. There's already some great, excellent evidence-based programs and community collaboratives such as Operation Access in the Bay Area. A lot of these programs are detailed out or linked in the manual, and so I've really used these as foundations, and I hope to speak with the leaders, and maybe some of them are on this call today, to talk about their trials and tribulations as they've moved this forward, because we're still kind of in a fledgling phase here. Utilize your local ACS chapter, any state-based nonprofits targeting colon cancer. We've got several in our state. So I give nods to our Nevada Cancer Coalition and the Nevada Colon Cancer Partnership. Use the appendices in the manual to help find others. And here, this webinar that was from a prior mini webinar was really great, and I was able to review that as well, so I give you the link to that. And so what have we learned? So some tactics are more valuable and effective than others. And so I've given you, I think, 7 of those tactics that I've found that have really been helpful in moving our program forward and making it a dramatic success. No matter what, there's always going to be challenges. There's a term called the known unknowns. You know that something is going to challenge you, but you don't know what it is during the planning until you roll it out and implement it. So those known unknowns will happen. So you have to meet those as you go forward, and that's exactly why you study your program, and then you act upon it and continuously improve it in a quality cycle. Partnerships are really key here. I couldn't do this without the joint collaboration of not only our staff and my executive staff, as well as our Nevada Cancer Coalition, the American Cancer Society, NCCRT, and many other entities locally, especially our health systems and GI docs, to make all this happen. And ultimately, if you're on this call, you have to be one of those champions to help move your programs forward and move your systems and really bend that curve downward, so that we have a noticeable increase in screening rates and a notable decrease in colon cancer-related deaths, because that's the end game. So I've given you web links to the manual and other resources here. And so I do see that there's been several questions. So I'm going to pause, and I will turn it back over to Mary. So I appreciate everyone's attention, and we will sort through some of these questions now.
Excellent. So thank you. That was just wonderful. I'm not sure any one of us could listen to that presentation without feeling a little bit lazy. So just a wonderful overview and an excellent way to bring the manual for life, or to life, excuse me. So I just wanted to highlight a few additional resources in addition to the ones that Dr. Crawford mentioned. One is that we do have a 4-pager backgrounder that summarizes a lot of what Dr. Crawford presented, what primary care docs can do to support the 80x18 effort that's available on our website. We have one coming out very soon on what women's health providers can do to support 80x18, and that's going to be co-branded with the American College of OBGYNs, which I think will be a real nice addition to the partners that we can work with. Of course, the tools that he just mentioned for community health centers, a new CDC online course for providers, a continuing education is available on our website. And then I did want to bring everyone's attention real quick to the 80x18 Communications Guidebook. So this is the resource I just mentioned. If you're courting some other primary care docs who or clinicians who you'd like to work with, we do have this tool on our website. It outlines very quickly 5 things that primary care docs can do to help support the 80x18 effort. So take a look at that. You might find it useful in your efforts. Dr. Crawford mentioned 2 of these 3 resources, but I also wanted to take a minute to mention the free CDC online course that is available on NCCRT.org. This is a real nice, extremely comprehensive tool that answers pretty much everything you can think of about the quality of conducting colonoscopy. There's one course for primary care that's actually narrated by the NCCRT chair, Dr. Richard Wender, and a second that's designed just for GIs by and narrated by Dr. Lieberman, and they're wonderful resources for your partners. We also have a communications guidebook that I hope you'll check out from our website. This goes over some tested messages that were specifically designed to resonate with the unscreened. And in fact, one of the things that is an important takeaway is that the unscreened really want to hear that there are take-home testing options available. So the idea that there are affordable options, less invasive options was extremely important, and there's a whole host of other information in the guidebook, so I encourage you to check it out. And then finally, thank you to all of you for listening, and we do have time for questions, so I will try to get through as many of these as possible, and we have we're going to the top of the hour, so go ahead, and if you have a minute in the question, go ahead and submit it, and we'll just kind of take these one by one. So, Dr. Crawford, at the very beginning of your presentation, someone asked, in terms of FIT screening, what's an average goal for FIT return rates for an FQHC? What do you recommend in terms of what the goal in that area should be? Well,
I'd like to address that twofold, as far as FIT as well as colonoscopy screening. So, return rates, as expected, were pretty low initially. And again, this gets to that tactic where you have your care coordinator. This person is really your champion / badger of your patients to make sure that they get their tests done, calling, finding out what's the story. So we were able to go from an approximately 30% FIT return rate to approximately 77% FIT return rate. And so I think that that's probably, I generally say there's about an 80-20, 80% return rate, 20% no matter what you do are not going to return it. So we try to face that challenge and meet the needs of that 20%, but sometimes no matter what you do, you can't get a hold of them. And for I'm scrolling through the folks that are from community health centers, and they know what it's like to have disconnected phones, bad addresses, et cetera, et cetera. So hopefully a lot of people are nodding their heads right now along with me. But as far as colonoscopy goes, again, this is where the care coordinator comes in, and the predictions, and based on some evidence and reviews that I've done of the evidence, that when you have your care coordinator or patient navigator that handholds your folks through the picking up the prep, going to their colonoscopy appointments, you can approach 98%. And so what we don't want to do, and of course my GI colleagues are already saying this, is that, we're going to offer this service. We want the patients to be there. And I 100% agree with that, and I feel that my community health center is required and mandated by me to make sure those patients are there, so we're not losing one of those patients. So, and that includes inadequacy of prep, showing up on time, et cetera, et cetera. So that's really vital to the success of your continued collaboration.
Excellent. And I will just say, in terms of what a specific goal should be, this just underscores the very point you made, Dr. Crawford, of just figuring out what your baseline is, what's your baseline now, and then try to improve. You don't necessarily have to start off right at the bat comparing yourself to a 77% return rate, but figure out where you are now and try to course correct it and figure out how you can adjust and make that better. We did get a question for the Spanish video for FIT instructions, and I have very good news in that we did mention some of these resources in the Community Health Center manual. And since the manual was released, a lot of resources in many languages and many different literacy levels are now available on Northwestern University's website. So I can go ahead and share that link with everyone after the webinar. It's just an awesome resource.
Sorry to interrupt. The resources I use, I don't have them up right now because I'm scared to adjust my computer. But you know, they're ones that I found. I mean, you know, we don't say to use Google too much, but Google can help out in many ways, and YouTube is chock full of all kinds of good stuff. But I do recommend that you make sure that you review said videos before you post them onto any websites or anything like that, and make sure that the Spanish translations or whatever other translations are culturally appropriate for the population you're serving. So.
And that's one of the nice things about this Northwestern library of resources is that they had an expert panel review for literacy level, accuracy, approachability, a whole bunch of different things. So I'll send it around. I think folks will really like that resource. So a question from Anikia, what are CLIA-waived tests?
Great question. So I always forget who knows which acronyms not, but CLIA stands for Clinical Laboratory Improvement Amendment. So in order to provide testing in your office, you have to have CLIA waivers. So it's one of our least favorite. Sorry if there's any CLIA people on the call right now, but you know, very paperwork intensive, time intensive, but it's a process that allows you to do in-office laboratory testing, be it strep tests, urinalyses, pregnancy, and now the FIT is available as well. This includes guaiac cards, potassium hydroxide microscopy, et cetera, et cetera. So you can tell I've just been through this process. So.
And a question for Kevin. Kevin, you might need to clarify. It said, you asked if Dr. Crawford can share the template from his practice, but since we're not answering these until the end, I'm not quite sure which template you're referring to, so maybe you can submit another question and we'll figure out if that's something that we can share. So Keith Winfrey asks, Dr. Crawford, where do you send the uninsured FIT-positive patients for a diagnostic colonoscopy? How long does it take to get the patient scheduled, and how well does the process work?
There's two components to that. Number one, we have multiple excellent resources in our community. One is a discount healthcare network called Access to Healthcare Network, and so we have a program with them. And if a patient qualifies and they are FIT positive, they get automatically moved through the continuum of screening to a free colonoscopy. And so that's one excellent resource. The second resource is the one that I'm cultivating with what we're calling the Project Cancer Screening, or colon cancer screening, within the Reno and Sparks area that I had kind of detailed out, and that's for our 60 free colonoscopies that are on reserve for the folks that don't qualify for any other programs, uninsured, they have no other payer source and no other methodology to get them to colonoscopy, and that's where we have those 60 available to us. As far as how long it takes to get scheduled, you know, our GI colleagues, the groups in town do a dynamite job at getting people in on a priority scheme. Just like, you know, many of our specialists now are being challenged with an influx of patients, and that's leading to some wait times. We're still able to get them in fairly quickly because they do know that there's priority with the FIT positive folks and identifying them for colon cancer sooner than later. And I would say overall, the last part of that, the process, our process works very well when you have care coordination involved. Leave it up to the doctors. Going to break down a little bit. Leave it up to your very busy MAs. It's going to break down a little bit. Have those care coordinators. They're really the glue to stick it all together. And if your primary care office can have a care coordinator that connects with the GI office's care coordinator, then that glue is even stronger. And that's what I am promoting with our GI folks as well.
Excellent. And I can send around that link again. It was in Dr. Crawford's presentation about the links of care webinar that we hosted this past August, which really goes into a nice bit of information about 3 communities that have established different processes and how they made those work. So very specific question, any recommendations for getting the LGBT community screened, particularly transgender individuals?
That's, you know, clearly we always make sure that we're open and available no matter the patient type, And so I don't have any specifics comments towards that, but I do know that we have this opportunity available to all patients regardless. Again, the cultural sensitivity and competency towards the LGBT community is vital to the success of any FQHC, and I think that making sure that you're providing the appropriate materials and guidance is key. But I don't have any specific links or other information available at this point.
Yeah, and that's one area where I don't think I've seen any tailored materials or any suggested strategies. So if anybody on this webinar has advice, please do shoot them our way, and we can take a look at them and perhaps include them in the next version of the manual, because it is a very important community. And so here's Kevin again with elaboration on exactly what he was looking for. Can Dr. Crawford share his cost savings template? And we will be making the slides available if you've not already received the PDF of the slides. But Dr. Crawford.
Yes, and basically, I mean, I created an Excel spreadsheet based upon what the manual shows. I don't have the page on the manual that talks about how to complete the calculations, but it is in there. And I created basically just a easy calculation Excel spreadsheet. I do have the numbers, the cost-saving numbers are referenced in the spreadsheet as well, so I can get those references to you, Mary, and if you could distribute to the group.
I think that people would really appreciate that. We always get a lot of questions about cost, so I think that is an excellent resource to share. So
sure.
Thank you. Can you share an example of what a successful ideal standing order looks like?
So basically, my recommendation is you always have to think about the procedural steps and create a flow sheet. I'm a big proponent of flow sheets. Work through them. They should be appropriate to the staffing levels credential, and work with your staff to see where their barriers or breakdown within the flow sheet occurs. And for me, when it comes to ordering a simple test like FIT, it's really about having your diagnostic code, which are our lovely ICD-10 codes, which everybody knows and loves now since October 1st, as well as your lab order code. If you use Quest or LabCorp or other specialty lab, they usually have a lab order form or code, and some patient instructions, and that can be delivered in by any staffer with a script as well as a handout, and pretty much at the point of care. And say, a lot of times with my medical assistant or care coordinator, I say, hey, I'm ordering a FIT, and it's pretty much enough said from there, and they know what to do from there. So that's kind of the process that we've gone through. And training and retraining, I can't tell you how important that is.
Okay, great. Then a very specific question. I don't see the FIT versus colonoscopy graphic that you showed. We can try to find that and send that around after this call. I do believe it is in the manual.
That one I think I took from the primary care manual, which you also had referenced.
Yep. So we'll find that and make that clearer in the follow-up. So thanks for the question. We've got about 5 more minutes left for questions, so we'll try to get through the last of these. When you speak of community and getting everyone involved in the 80 by 18 effort, how can a community group like law enforcement, faith-based communities, et cetera, help with this mission? Could you provide an example of what that would look like? We actually do have an 80 by 18 fact sheet on how community groups can get engaged, and I'd be happy to send that link around. We are looking to do in the new year another one of these mini webinar series featuring some communities that have really, community organizations that have really hit this 80 by 18 effort out of the park. We'll get that around. And Dr. Crawford, I don't know if you've had any particularly good experience with community partners that you wanted to highlight?
I don't specifically, but what our plan is moving forward, there's a very large thrust within the nation to get community health workers more engaged Nevada is taking that to heart and moving some legislation forward on community health workers, and our plan is to bring them into the fold within our care management department and allow them, as well as myself, to work on community-based campaigns which will specifically target faith-based communities and other outreach communities that we serve. And so that's kind of our moving forward plan.
Yeah, and we actually do have a presentation on this upcoming at the Roundtable annual meeting, and I think it sounds like a topic of interest of many, so we can perhaps commit to a webinar on that in the new year. It's a great question. Another question for you, Dr. Crawford. What is the best solution to lengthy lab requisition forms?
I laughed a little bit while I was on mute, but yeah, those lab requisition forms can be difficult. So I'm hoping that the majority of your lab ordering is being done through an electronic medical record to alleviate some of that paper burden, because I can very specifically order it within my EMR and it just kind of prints off or sends it electronically to the lab. So we don't really have to go through a lot of those paper-based processes. However, thinking back to the paper days, we had label printers that had all the patient identifiers, address, phone numbers, all that, and so we would get a sheet of labels that would be readily available to us, and then I would just take a label off and pop it on there, so I don't have to write in all that address, et cetera, et cetera. So if your support staff, if you don't have a label printer, then have your support staff do it. You check off the fit, you sign it, and have your support staff fill out the rest so you can keep moving as the clinical provider. So that's kind of the best options I have for you right now.
Okay, great. And we have just a few more minutes, but a question about what recommendations do you have on how FQHCs can sustain program funding sustain a program when the funding runs out, and they're specifically thinking of care coordinator positions. And I will share that the Roundtable has commissioned the University of Colorado Denver School of Public Health to explore this topic for us, and they are collecting different examples of how FQHCs and other institutions have been able to pay for screening navigators or care coordinators, which are so important to the screening process. So I don't have a ready answer now, but we are trying to get some good examples out there to all of you. And Dr. Crawford, I don't know if you have any specific advice about that in the short term.
I think that it's, you know, the future success of these types of positions are really you know, mandated based on a transition, I think, to a value-based programs as we move forward in the insurance industry, and that's being driven by Medicare. And I think, you know, the valuable work done by NCCRT, ACS, and acknowledging these positions and how they're vital to the success of any, for instance, for us, for patient-centered medical home, the 2014 standard, I think it's standard 5 is care coordination. So, I mean, we can't be a PCMH without care coordinators. So how do we pay for them? Well, that's key, and we have to continue to look at grants. We have to accept that we're in a little bit of a transition period going from volume-based to value-based health insurance programs, and having your PCMH accreditation kind of positions you well for that future and hopefully more funding. The other thing that I would impress upon everybody is that, unfortunately, FQHCs cannot bill care management codes that just came out by Medicare at the beginning of the year, and I find that to be difficult for me, because I think that we offer so much care management and care coordination within federally qualified health centers that we should qualify for those codes. Now, there's lots and lots more to that story, but if you're a legislator or have any power or ability to lobby for that, I would hope that we can make that change and get those codes billable for FQHCs, so we can start paying for these positions and getting paid for this awesome work that we're offering.
Yes, absolutely. All right, well, wonderful. We're at the top of the hour. We didn't get to all our questions, but we can answer some of those by email. And a huge thank you for Dr. Crawford for that absolutely outstanding presentation, and thanks to the CDC for providing the funding to make this webinar possible. We do have a couple great webinars coming up, one next month on lessons learned from New York City's C5 Coalition, which is just an awesome example of a public health coalition in action. And then in January, we're looking to get an overview from our friend Faye Wong over at the CDC on the new CDC CRCCP program. How has it changed from the last funding cycle, and how can we in public health help support those efforts? So for more information, please email me. We'll send a follow-up email to all of you with some of the resources that we mentioned. Thank you all for joining us today, and have an absolutely wonderful afternoon.
Thank you very much.